Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
If you're an interventional radiologist looking to stay at the cutting edge of your field, you are in the right place today.
We are tackling a big one today.
Yeah, we really are. We are looking at the highly anticipated 2026 AHA, ACC, ACCP, ACP. Well, you know what? I'm just going to call it the massive new multi-society guideline for the evaluation and management of acute pulmonary embolism in adults.
It's quite the alphabet soup of endorsing societies, isn't it?
It really is. But honestly, that massive list just underscores how incredibly multidisciplinary PE care has become. You really can't manage this in a silo anymore.
Definitely not.
And the stakes for getting this right have never been higher. Right off the bat, the guidelines note that less than 10% of patients evaluated for a suspected PE actually end up being diagnosed with one.
Right, but when that diagnosis is confirmed, the pathway from the emergency department to your reading room and potentially straight to your interventional suite has to be seamless.
Exactly. You are a vital member of the medical team, and you need to know exactly when to reach for a catheter, and just as importantly, when to hold back.
Which is exactly why we're here.
Right, so our mission today is extracting the most critical updates tailored specifically for you.
And it's the perfect time to do this. The landscape of acute PE management is constantly shifting, and this de novo 2026 guideline represents a leap forward. If you've been relying on the historical classifications, the old 2011 AHA massive and submassive categories, or even the 2019 ESC risk categories, you need to update your mental models. The way we assess severity in therapeutic pathways has been completely overhauled.
Okay, let's unpack this, because for years, submassive and massive were the buzzwords that triggered every single consult. Why did the writing committee decide to just throw those labels out entirely?
Because they were simply too blunt. The submassive label just didn't capture the sheer heterogeneity of patient outcomes.
Right, they were just too broad.
Exactly. You can have a submassive patient who just needs a little bit of supplemental oxygen and another submassive patient who is 2 hours away from completely crashing and coding. The clinical buckets were too wide to be genuinely useful for modern triage.
So it's the new framework.
To replace them, the 2026 guidelines introduce a highly granular paradigm. They are the acute PE clinical categories, and they range from category A all the way to category E.
So we're moving from two big buckets to a highly specific spectrum. Let's walk through these, starting from the lowest risk, because this is going to dictate exactly how the team responds.
Sure. Category A is your subclinical PE. These are the incidental, completely asymptomatic findings you might catch on a scan that was ordered for an entirely different reason.
Like a routine oncology follow-up.
Precisely. Next is Category B, which represents symptomatic PE, but crucially, with a low clinical severity score.
And they divide Category B up further, right?
They do. It's broken into B1, which is subsegmental, and B2, which is non-subsegmental.
Why the distinction?
That distinction is vital for the emergency medicine and internal medicine teams because it dictates triage. It helps determine whether the patient can be managed safely as an outpatient or if they require hospitalization.
Okay, so A and B are relatively stable, but Category C is where the friction really starts for the inpatient team, and where you, as the radiologist, really start to get pulled into the orbit of the clinical decision-making.
That's right. Category C patients are symptomatic with an elevated clinical severity score, and this is where the new guidelines demand precision.
How so?
Category C is broken down into 3 subcategories based entirely on biomarkers and right ventricular function. C1 means normal RV and normal biomarker.
Got it.
C2 means you have an abnormal RV or at least one abnormal cardiac biomarker, like an elevated troponin or BNP.
And C3.
C3 means you have both, an abnormal RV and elevated biomarkers.
And from there, we step into the danger zone, Categories D and E.
Yes. Category D represents incipient cardiopulmonary failure. D1 is characterized by transient hypotension, while D2 describes normotensive shock.
Those D2 patients are tricky.
Very tricky. They might have a totally normal blood pressure, but they are showing signs of isolated tissue hypoperfusion. Lactic acid is climbing, mental status might be altering.
And then Category E.
Finally, we reach Category E, which is full cardiopulmonary failure. E1 is your classic recurrent or persistent hypotension with cardiogenic shock, and E2 is the most severe presentation, encompassing refractory cardiogenic shock or outright cardiac arrest.
It is a much more logical way to stratify risk. But there's another modifier they added to this schema that I found really compelling, the R modifier. How does that fit into this A through E spectrum?
The introduction of the R, or respiratory modifier, is of nuanced detail. Historically, risk stratification for PE has heavily favored hemodynamic compromise.
Right, we're always looking at the blood pressure in the right heart.
Exactly. But the writing committee recognized that some patients have presentations dominated entirely by respiratory failure, rather than cardiovascular collapse.
So what does the R do?
An R can be added to the subcategories, or even stand alone in some clinical contexts for patients with prominent respiratory abnormalities, like severe hypoxemia requiring high-flow oxygen, or outright ventilatory failure.
So you got to have a category C2R, meaning they have some RV strain, but their primary issue right now is that they can't oxygenate.
Exactly. It paints a much clearer picture of the physiological threat the patient is facing at that exact moment.
This directly impacts you in the reading room and the IR suite. These categories A through E are what will now dictate when your pulmonary embolism response team is activated. And more importantly, they are the specific criteria that justify when your advanced therapies are actually warranted. We'll get into those specific therapies and when you should scrub in shortly, but first, let's talk about the diagnostic workup. Because before you can categorize the patient, you have to confirm the diagnosis and assess the physiology.
And when it comes to confirming acute PE, computed tomography pulmonary angiography CTPA remains the gold standard.
Which is great news for radiologists.
It carries a Class 1 level of evidence, a recommendation, meaning it is strongly preferred over VQ scans for diagnosing acute PE. It's wide open, highly accessible, and offers excellent diagnostic performance.
But here is where the guidelines essentially mandate a shift in how you dictate your read.
Yeah.
It's no longer just about confirming the presence and location of the clot, right?
Right. What's fascinating here is how the radiologist role is elevated. Finding the thrombus is merely step one. The radiologist now plays a foundational role in risk stratification by assessing the right ventricle.
So evaluating the physiological toll the clot is taking on the RV is step 2.
Yes, and it is entirely mandatory for these new clinical categories to actually work.
Which means when you're dictating that CTPA report, you need to be detailing specific evidence-based parameters of RV dysfunction. You can't just say large clot in the right main pulmonary artery and sign off.
Precisely. The guidelines list exactly what you should be assessing and reporting, whether you are looking at a CTPA or an echocardiogram.
Let's list those out for the listeners.
You need to dictate the RV to LV end diastolic ratio and the RV end diastolic diameter. You should be looking for that tricuspid annular plane systolic excursion to see if the right heart is starting to give out.
And McConnell's sign.
Yes. You need to look for RV free wall hypokinesis with sparing of the apex, which is commonly known as McConnell's sign. And you should be reporting on inferior vena cava respirophasic collapse.
These aren't just descriptive flourishes to make a report look thorough.
Not at all. They are the data points the clinical team needs to push a patient from a stable category B into a high-risk category C.
Now wait. As an interventional radiologist, my eyes are naturally going to be drawn to the sheer volume of the clot. If I look at a scan and see a massive bilateral saddle embolus, my instinct is to think, that's a huge problem, this patient is high risk. Anatomic characterization of the thrombus burden is obviously helpful for planning a procedure, but are you saying the size of the clot doesn't actually dictate the risk?
It's completely counterintuitive, but yes, that's exactly what the guidelines are saying. Current data does not support using thrombus burden quantification, like calculating a modified Miller score, for short-term risk stratification.
That is a paradigm shift. So a massive clot doesn't automatically mean we rush to reperfusion therapy?
It does not. The sheer volume of the clot does not determine if reperfusion therapy is indicated. You could have a massive clot burden with minimal hemodynamic or RV strain because the patient is compensating well.
And vice versa.
Conversely, you could have a much smaller, strategically lodged clot that is causing severe right heart failure and impending shock. The physiological response, not the anatomical volume, drives the risk category.
That is a critical distinction. You already know how to pull a clot out, but the guidelines are changing the rules of engagement for when you pull it out. So let's step into the interventional suite and talk about advanced management strategies. You've got catheter-directed thrombolysis, or CDL, and mechanical thrombectomy.
This is a space where interventional radiologists provide life-saving care. But patient selection is paramount. The 2026 guidelines provide strict new guardrails on exactly who should be on the table.
Let's break that down.
If a patient is in category E1, meaning they have recurrent or persistent hypotension with cardiogenic shock advanced therapies, including CDL and mechanical thrombectomy, are deemed reasonable.
Okay, so the E1 crashing patient is a clear candidate. What about the D categories? The incipient failure patients?
If they're in category D1 or D2, the guidelines state that advanced therapies can be considered. They are on the precipice, and intervention might prevent the plunge into full cardiopulmonary failure.
But here's where it gets really interesting and maybe a bit frustrating for an IR practice. What about the rest? What about a category C2 patient?
The stable but strained patient.
Right, they've got an elevated troponin, the RV looks terrible on the CTPA, maybe you see McConnell's sign. My instinct as an interventionalist would be to get in there and relieve that pressure before they decompensate. Are the guidelines saying to keep them off the table?
That is what they're saying, and I know that causes a lot of tension in the multidisciplinary meetings. The guidelines state that advanced catheter-based interventions are generally unwarranted for patients in categories A through C1.
And the C2 and C3 patients?
Even for most C2 and C3 patients, unless they are deteriorating despite optimal medical therapy, if they don't have that hemodynamic instability pushing them into category D or E, catheter-based interventions shouldn't be the default.
Why? If the plumbing is clogged, why not unclog it?
Because the clinical benefit simply isn't there in the data for the lower risk categories to justify the procedural risks. Every time you cross the venous system and enter the pulmonary arteries, you risk pulmonary artery rupture, access site bleeding, or dislodging more thrombus.
So medical management is still king there.
For a stable category C patient, therapeutic anticoagulation is still the safest, most effective primary strategy.
But when you do have the right patient on the table, the D or E category patient, the guidelines are fully supportive.
Absolutely.
For catheter-directed thrombolysis, they recognize the evolution of the gear, from standard multi-side hole transcutaneous catheters to specialized devices using ultrasound-assisted thrombolysis or expandable infusion baskets.
Yes, the technical options are expanding rapidly, but the guidelines also drop a crucial logistical mandate for what happens after you use some of this gear, specifically regarding mechanical thrombectomy.
Right, because mechanical thrombectomy is immediate physical extraction. You pull the clot, the hemodynamics improve on the table, and the patient looks great.
They might look great, but if a patient undergoes mechanical thrombectomy and is hemodynamically stable afterward, the 2026 guidelines stipulate they absolutely cannot just be sent to a standard floor bed.
Where do they have to go?
They must be admitted to a level of care with continuous telemetry and, crucially, nursing staff who are familiar with the post-procedural complications of the device you use.
So you can't just do the case and sign off. It requires tight coordination with your ICU or intermediate care units to ensure the post-op monitoring matches the procedural intensity.
Exactly.
Now, I want to talk about one of the most stressful findings you might encounter during a workup. Imagine you're reviewing an echo or a chest CT, and you see it. A free-floating intracardiac clot in transit.
It is a terrifying finding. You're just watching a massive thrombus bouncing around in the right atrium or ventricle.
It's not exceedingly rare.
No, it's discovered in roughly 2 to 4% of patients diagnosed with acute PE.
So what do the new guidelines tell us to do? Do you immediately rush them to the IR suite for an aspiration thrombectomy? Do you call cardiothoracic surgery to open them up? Or do you push systemic TPA?
This is one of the most honest parts of the guideline. They calmly acknowledge a frustrating reality in medicine. High-quality comparative data simply does not exist yet for this specific scenario.
Why is there no data? It seems like such a critical problem to solve.
Think about the logistics of trying to run a randomized controlled trial on this.
The stakes are too high.
You cannot ethically or logistically randomize these crashing patients into surgery versus catheter versus wait and see with heparin. Because of that, we don't have robust trials comparing CDL versus MT versus systemic thrombolysis versus open surgical embolectomy for a clot in transit.
So you're flying blind.
Not blind, but you are relying heavily on clinical judgment rather than a strict algorithm. The guidelines emphasize that a clot in transit requires a highly personalized, multidisciplinary approach.
So it's a team decision.
Every decision must be weighed carefully by the response team, based on the patient's immediate physiological state, their bleeding risk, and their surgical risk. The surgeon, the intensivist, and you, the interventionalist, have to look at the patient and make a collective call.
While we are on the topic of medical management supporting your procedures, there is a quick but vital call-out regarding the foundational anticoagulation these patients receive.
Yes.
For patients with acute PE who require initial parenteral anticoagulant therapy, the guidelines officially recommend low molecular weight heparin, or LMWH, over unfractionated heparin.
This is a strong Class 1 recommendation. LMWH has more predictable pharmacokinetics. It doesn't require the constant APT monitoring and trip titrations that unfractionated heparin does, and the data shows it reduces the risk of recurrent VTE with a lower incidence of complication.
Like heparin-induced thrombocytopenia. So when you're reviewing a patient's chart, before you take them for a procedure, ensuring they are on that optimal foundational medical therapy is just as important as planning your catheter trajectory.
Absolutely.
Now let's shift gears to a topic that represents a massive shift in interventional practice. For decades, placing in a filter was a bread-and-butter procedure for many interventional radiologists.
It really was. IVC filters were designed with a very logical mechanical premise. Intercept before they can migrate to the pulmonary circulation. If there's a clot risk, drop a filter in to catch it.
But the 2026 guidelines have laid down a major marker regarding routine IVC filters. This isn't just a slight adjustment, it's a fundamental pullback.
If we connect this to the bigger picture, routine IVC filter placement in therapeutically anticoagulated patients is now a Class 3 harm recommendation.
And that's backed by a level of evidence A.
Yes. We used to put these in almost prophylactically, but over the years, the long-term data caught up with us.
What did the data show?
The evidence regarding their overall benefit, especially when weighed against long-term complications like filter fracture, migration, IVC thrombosis, and the fact that many retrievable filters are never actually retrieved, prompted a severe reassessment. They should not be performed routinely.
A Class 3 harm rating is as definitive as it gets in guideline language. It explicitly means the risks of routine placement significantly outweigh the benefits. The filter itself becomes the hazard.
That's right.
So, as an interventional radiologist, when are you actually supposed to place them now? What are the strict indications that keep an IVC filter as a viable tool?
The indications have been narrowed to very specific high-risk scenarios. You should only be placing an IVC filter when anticoagulant therapy is contraindicated.
Give me an example of that.
A patient comes in with an acute PE, but they also have active catastrophic gastrointestinal bleeding, or they just suffered a hemorrhagic stroke. You obviously cannot give them heparin.
Okay, that makes sense.
In that scenario, the mechanical barrier of an IVC filter is entirely justified. The only other recognized indication is when there is documented recurrent PE despite optimal therapeutic anticoagulation, specifically in patients who fall into those higher risk categories B through E.
But outside of those strict parameters, contraindication AC or failure of AC, the IVC filter should stay on the shelf in the supply room.
Exactly.
That is a practice update that every IR needs to integrate. Now, we've talked a lot about the friction points, when to intervene, when to use a filter, how to handle a clot in transit. Navigating all of this requires a team, and the guidelines formalize this through the Pulmonary Embolism Response Team, or PERT.
Yes, the guidelines explicitly recommend the use of PERTs to improve the timeliness and quality of care. The days of a single attending making a siloed decision on a complex PE are fading.
And the data supports this team-based approach, right?
The data is incredibly robust. Establishing a dedicated multidisciplinary team operating much like a code stroke team or a STEMI alert streamlines the entire workflow.
What are the specific outcomes?
Studies show that when a PERT is activated, it significantly reduces the time it takes to achieve therapeutic anticoagulation. Interestingly, PERT implementation is also strongly associated with a decrease in the use of IVC filters, which aligns perfectly with the updated Class 3 harm recommendation we just discussed.
Because when you have multiple experts consulting, the default to drop a filter diminishes.
Exactly. Furthermore, PERTs help reduce overall hospital length of stay and bleeding complications.
And as an interventional radiologist, you are a foundational pillar of this PERT wheel. Your expertise in image interpretation, assessing the RV on that CTPA, and your ability to deploy advanced catheter therapies when the patient crosses into category D or E is what makes the PERT function effectively when a patient is spiraling.
But your responsibility and the team's responsibility doesn't stop when the patient leaves the hospital.
So what does this all mean for the patient long term? Let's talk about the long game. What do the guidelines say about post-acute care?
Post-acute care is a major dedicated focus of this 2026 guideline. We used to treat the acute clot and consider it a job well done. But the data shows that up to half of patients will experience ongoing dyspnea, exercise intolerance, or functional impairment, even after 3 full months of optimal therapeutic anticoagulation.
Half of patients. That's a huge burden of chronic disease.
Exactly. So the guidelines detail a strict 3-month follow-up evaluation protocol. For patients with those ongoing symptoms at 3 months, a comprehensive diagnostic evaluation is required to assess for chronic thromboembolic pulmonary disease, or CTPD, and the more severe chronic thromboembolic pulmonary hypertension, or CTEP.
Because if those conditions develop, the patient might need entirely different interventions like balloon, pulmonary angioplasty, or pulmonary thromboendarterectomy down the line.
Right. It ensures that long-term the clots you treated in the acute phase don't go unrecognized and untreated. It formalizes the idea that it is a chronic journey for many patients, not just an acute, isolated event.
Let's quickly recap the journey we've taken through this massive document. We explored the paradigm shift away from the old massive and submassive labels, replacing them with the precise clinical categories A through E, including that new R respiratory modifier.
And we discussed the critical mandate for you in the reading room to assess and dictate right ventricular dysfunction parameters like tricuspid annular plain systolic excursion and McConnell's sign.
While remembering that the actual volume of the thrombus doesn't dictate short-term risk as much as the physiologic response does.
We also clarified the precise patient selection criteria for your interventional suite. Catheter-directed thrombolysis and mechanical thrombectomy are reserved for the highest risk categories like E1 and potentially D1 or D2, while keeping stable patients off the table.
We detailed the new continuous telemetry requirements for post-thrombectomy care. We talk about the lack of data for a clot in transit.
And crucially, we highlighted the strict new limits on routine IVC filters, cementing them as a Class 3 harm recommendation for therapeutically anticoagulated patients.
It is a massive amount of information to synthesize, but this is what you need to know to stay at the top of your game, whether you're dictating a scan or prepping the IR suite.
It is. And as comprehensive as these 2026 guidelines are, the writing committee included an entire section on evidence gaps and future directions that I find endlessly fascinating.
Oh.
This raises an important question for anyone in radiology right now. With the guidelines explicitly calling out the future need for artificial intelligence in radiomics for aging a thrombus and refining risk stratification, you have to wonder, how long will it be until an AI algorithm reads your CTPA, perfectly categorizes the PE into the A through E schema, activates the pager, and alerts your interventional suite all before you've even finished dictating the scan?
The technology is moving incredibly fast, but for now, your clinical judgment, your ability to read the nuances of an RV, and your steady hands remain entirely irreplaceable. That's all for today. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.